Okay, be seated. All right, I'm ready to call you first.
Yes, call Dr. Foley. Dr. Foley.
Do you solemnly swear or affirm that testimony about to give you the truth, the whole truth, nothing but the truth?
I do.
Call the deal.
State please swear.
May proceed.
Thank you. Counsel. Ladies and gentlemen, jury welcome. Dr. Foley, could you please introduce yourself to the jury?
Yes, good afternoon, everyone. My name is Michael Foley. Last name is Foley.
Dr. Foley, tell us a little bit about what type of doctor you are.
Well, I'm a diagnostic radiologist, first and foremost, and also board certification in nuclear medicine.
Tell the jury a little bit about what board certification is.
Okay. So when you go through your specialty training, you could go right out into practice after your specialty training by having done that training at a certified center. Most people would like to attain board certification, so that's a series of tests that we take, oral and written exams, and if you pass those, then you're considered board certified. If you don't pass them, then you're considered what's called board eligible. So board eligible means you went to the certified university that can teach radiology, orthopedic surgery, what have you. But it means you're eligible to take the boards, but you either haven't taken the boards or you took the boards and you flunked.
Let me go back a little bit, because I skipped over some important stuff. I graduated college, medical school, residency. Could we go through that too?
Sure. So I grew up in Detroit, Michigan. I went to undergraduate school at Oakland University. From there, I went to medical school at Northwestern University in Chicago. Got my MD degree in 1978. From there, I went out to the University of California, San Diego to do my medical internship. And so that is basically where you rotate through 12 different specialty areas of medicine one month at a time. And kind of that first year internship is kind of used by most doctors as giving you a broad overview of medicine. So for many folks that haven't quite decided what area they want to go into, the internship is a good area to start, which most people have to do in the internship. So when I was in my internship, I decided I wanted to go into radiology, so I returned to my alma mater, Northwestern University in Chicago, did my diagnostic radiology residency program, which is your specialty training. During my senior year, I was elected chief resident of radiology, so that's an honor because you're picked by all your professors to be the one person to be called the chief resident that year. It also gives you teaching responsibilities to all of the residents in the program, so you're teaching people in your year and the years below you. So after finishing the residency, then you are board eligible. So I took the boards right away, and the written exam, the oral exam, passed them both and became board certified in 1982. I then stayed on at Northwestern an additional year to do what is called a fellowship. And a fellowship is an additional year of focused training. So my fellowship was in what is called whole body imaging. So CT, ultrasound, nuclear medicine, and of the entire body, head to toe. And so following that fellowship, it qualified me for being able to take a second board exam. This time it was in nuclear medicine, which has to do with using radioisotopes to visualize the body. So bone scans, brain scans, lung scans, things of that nature that fall under nuclear medicine. So after finishing the fellowship and finishing essentially the formal training at Northwestern University, I moved down to Tampa, Florida, joined a large radiology group in Tampa, was in 7 different hospitals, including the hospital right up the road here, Manatee Memorial Hospital in Bradenton. Also served at Brandon Regional Medical Center, University Community Hospital, UCH Carrollwood, St. Joseph Women's Hospital, Dade City Hospital, Newport Richie Hospital, and became, during the course of 20 years I was at the hospitals, chairman of several of those hospitals, including Dade City Hospital and Brandon Regional Medical Center for about 10 years, where I also served on the executive committee of that hospital for 10 years. Manatee Memorial, I went there as one of my first duties and worked my way up to assistant chairman of radiology at Manatee, and then from Manatee I moved to, was elected chairman at Dade City Hospital, so I then transferred my work up to that area. During the course of all those hospital years, a new board came out that you could take. It had never been offered before, and it was in interventional radiology, which is basically the invasive aspects of radiology. So normally you think of radiology as the doctor in the back room, so to speak, the reading room, reading the films. The doctor often never sees the patient. The technologist interacts with the patient, does the mammogram or the CT scan or whatever, and then the films are brought to the doctor, or right now they're moved by computer screen from one area to the other. Interventional has to do with doing procedures on patients, so it's hands-on. So you would see the patient, examine the patient, explain the procedure to the patient, show the patient their film so they can understand what is going on with them, and they can understand why somebody might want a biopsy, or why somebody wants an angiogram and an angioplasty, which is to look at blood vessels and then put a stent in the artery, open it up, or do pain management procedures by guiding needles under CT or fluoroscopic guidance down into the epidural space or the nerve root to try to get rid of the patient's pain. And so this board came available. I was doing a lot of interventional as well as regular radiology at the time, and so I decided to take that board when it first came out in '96 and passed it. So at that point in time, I achieved so-called triple boards in radiology, which is the diagnostic radiology, nuclear medicine, and interventional. The interventional is has a time limit on it of 10 years, and so I held that triple board status for 10 years between '96 and 2006. When it came up for renewal, I let it pass because in 2003, after working in the hospital for 20 years, '83 to 2003, I opened up my own imaging centers in the Tampa area, 2 of them. And because you can't do angiograms and angioplasties at an outpatient imaging center, there was no use for me to go retake the board again. It board certified in something that I wasn't going to be able to do in my office practice. And so I worked at those offices, ran those offices, read films at those offices for about multiple years. I forget exactly how many, until about 2009, when Tampa General Hospital came to me and basically wanted to buy my 2 imaging centers and made a very good financial offer for those centers, so I sold them those centers. And all along in my practice, I've been asked to serve as an expert in various cases. In other words, where an attorney would mail you a case and want to get your opinion of what's going on with the film, to help guide them, whether whatever question they may have have about the films. And so that started in '87 when I was out of practice about 4 years, and that's slowly grown over the years as well, such that when I sold my imaging centers, all of these things from the lawyers were still being mailed to me, and so I just sort of continued on the forensic radiology pathway in the past couple of years. And so that's why I'm here today, is because this case was mailed to me. I read the films on it, and then I was asked to come to court to explain the findings of the films to the jury.
Thanks, Dr. Foley. Can you just, so the jury can appreciate the rareness or distinction of being triple board certified, what percent of physicians are triple board certified?
Well, I don't know if I told the jury this, but the flunk rate for taking the regular diagnostic radiology boards is about 25 to 30% per year. So it's not like a given that just because you sit and take the boards, you're going to pass it. On average, about 75% of radiologists out there are board certified in one board. About 10 to 15%, depending on the year, have two separate boards in radiology, and about 1% have three separate boards in radiology.
Thank you, Doctor. When you were talking earlier about interventional radiology, is that sort of a branch of pain management? Were you doing surgeries of pain management?
Right, those are actually, they are classified as surgeries. They have the surgical CPT codes and so forth, even though you're not cutting the person open per se. You're guiding needles down to the spinal canal, spinal cord, the nerves, and so forth. So yes, it is a form of surgery. It's called essentially minimally invasive surgery.
Okay. Let's go back. Tell us a little bit about articles that you published, or chairmanships, or leadership in radiology that you held.
Okay, so I think I've got 34 publications now. Some of the very first articles that I published were in spine injury cases that were severe enough that the person became either quadriplegic or paraplegic. So I published on the kinds of findings that you would see in those kinds of cases, and then the kinds of surgical procedures that were done to help fix those fractures or dislocations or cord contusions, what have you, and how it would look radiographically so that other radiologists could recognize some of these special devices that they were using and so forth on the spine. Scientific presentation-wise, I've done probably, I think it's around 212 presentations over my 30 years so far. And leadership roles, you said, well, I told the jury about the assistant chairmanship at Manatee Memorial and the two chairmanships at Brandon Regional and Dade City Hospitals. Served on the executive committee, as I said, for about 10 years at Brandon Hospital. I've also served as the president of the Florida West Coast Radiologic Society, which is a radiologic society, as the name would imply, of all radiologists up and down the west coast of Florida, starting from the Panhandle and wrapping all the way around to Miami. So this is a membership where the radiologists would meet once a month to get together, and their dues would be used to pay to fly in somebody from outside of the Florida area, somebody from Stanford or Mass General or Mayo Clinic or whatever, to come and give us a lecture on some radiology topic and kind of talk to us about how they're doing things there, and that so we can compare notes to find out how we're doing things here versus what they're doing there, and sit and have dinner with the speaker afterwards and so forth. So that was great fun because I got to meet a lot of radiology leaders from around the country. I currently sit on the editorial board of the Hillsborough County Medical Association, the journal that is written through the Hillsborough County Medical Association as well.
Thank you, Doctor. I brought you here today. Could you please describe or define the term eggshell patient?
An eggshell patient?
Plaintiff.
So, eggshell patient, eggshell plaintiff, or whatever, but basically the term eggshell patient is one that has some underlying diseases going on. You know, if we're talking about the spine, they have some underlying degenerative change and so forth, to the point that if that person were to get in an accident, that person can be injured much more easily than an otherwise totally normal patient because of the fact that they're fragile. And so we commonly see this. I mean, an easy example, a good example is you have an elder person that's 80 years old and a younger person that's 20 years old, and they walk into the grocery store, the sliding glass doors open, and they both slip on some water and fall. The younger person gets up and they might have a bruise on the side of their hip, but the older person doesn't get up because they fractured their hip. And it's like, well, how can one person get a fracture and the other not when they both fell from the same distance? And the reason why is because the older person has other things going on. They've got osteoporosis, they have degenerative change, and it makes their bones more brittle and more susceptible to injury. So we commonly find this in the spine because if people have pre-existing degenerative changes like disc desiccation, like osteophytes, like disc osteophyte complexes, these patients' discs are not as sturdy and strong and resilient as, say, a younger person that's 15, 20, 25 years old. And when they get in an accident, it can seem relatively minor to the bystander, but yet to that patient, their body, it doesn't take much to break it, so to speak. And so an eggshell plaintiff is one that has underlying degenerative changes that can be easily injured when exposed to trauma.
Let me ask you about an analogy back there. Let's say I have a water glass, a long stem, real nice fancy water glass, and I'm pulling it out of the dishwasher and I bang it against the counter, and I see it's like a little crack in it. And so I think, okay, it's all right. I check it. You know, it holds water, everything seems fine. I'm not going to use this glass, obviously, for gas or something. But then when I go to set it down on the counter, and it's just the bottom, not even near the crack, it breaks. Is that analogy at all similar to an eggshell?
Yeah, no, I think it's actually a good analogy. I'm going to use that in the future. But I mean, the idea that there is an underlying defect present, and then, like you said, you're taking this glass and you just set it down sort of in regular fashion, and the sidewall of the glass falls apart or something like that. You go, how did that happen? I didn't slam the glass down or anything like that. But it's because the glass already has a crack in it, and it takes a little bit more to break the camel's back, so to speak.
Okay. Thanks, Doctor. Before we jump into what you did in this case, can you just give the jury an overview of just kind of what your opinion is, and then we'll talk about how you reached that and explain to the jury the different parts of the anatomy as well.
Yes. So in this case, I did not review a ton of medical records or go through the person's chart or anything like that. Being a radiologist, most of the time, the attorneys will send me the films. And from the films, or film, they will want me to figure out what's going on as best I can from the films. So in this patient, looking at the MRI of the cervical spine that was done on 6/26/13, we could see that the patient has evidence for prior surgery. They have what is called an anterior fusion, where they have a metallic plate and screw device that is going down and fusing the C5-6 disc space and the C6-7 disc space. So that's two of the lower disc spaces. And by fusing, that means you're screwing this up and down vertical plate into the vertebral body, so the discs at each level, the 5-6 level and 6-7 level, can't bend forward or backwards. And the reason that is done, just as a side note, is because if the person has degenerative disc disease or any kind of disc disease there, and the surgeon feels that's where the patient's pain is coming from, one of the ways to deal with it is to suck out as much disc, as much herniated disc as possible, and then plate that so that that area won't move, with the idea that it will no longer be available as you flex and extend your neck, that it will rub on the spinal cord, because remember, the back of the disc is poking into the spinal canal, and you have the spinal cord there, so if something's poking in, flex forward, that cord is going to be rubbing on that structure, that disc that's sticking out. So if they stop movement there, then at least when you bend your neck, that area won't be able to bend, and you won't be touching and untouching the cord at that level. So that sounds all good and everything, and normally for some folks that can be good, a good procedure. The problem is that when you fuse two levels, like was done here, C5-6 and C6-7, that takes those two disc levels totally out of play for being able to contribute to flexing or extending your neck. And therefore, it puts much more pressure on the disc above it, and the disc above that, and the disc below that, because those are the discs that now have to try to compensate and develop the full flexion or the full extension that your neck and your head are trying to achieve, even though those two disc levels aren't working anymore. So the medical term for the problems that you can get to the discs above and below is called adjacent disc syndrome. And what it implies is that the person has had a fusion, and now you're putting extra pressure on the discs above and below just with normal use of the neck. And it's very common that those discs will blow out, if you will, or herniate. And it's particularly common that they will give the person a problem if the person has been in some sort of accident, because you're quickly flexing and extending the area, and that one area is not flexing and extending at all, so all the weight and force can go on to the disc above and the disc above that and the disc below that. That is even further compounded not only when you have the fusion, but not only because you've had trauma with a fusion in place, but it's further compounded when the discs above and below the fusion have some sort of degenerative change in it, because the degenerative change makes that disc weaker, and therefore that disc will herniate much more easily than an otherwise totally normal disc. Which is, by the way, a very common scene where we have like a younger child in a car, and say the mom driving the younger child. We got a 12-year-old boy in the car, and we got the mom who was 45 or 50, and they get in an accident. They're both sitting in the front seat, both seat belted, and the younger child gets out of the car, and he's got a little stiff neck for a day or two, but he's doing fine. And the mom gets out of the car, and her neck is hurting her, and it never seems to go away. And then a couple months later, whatever, they get an MRI and oh, she's got a couple of herniated discs. And you would scratch your head and say, well, why did she get the herniated disc and not the 12-year-old? And generally, it's thought that the younger folks, their discs are more resilient and can stretch and still not herniate, whereas the older person has a more brittle disc, especially as the discs begin to dry out and desiccate, and those discs will herniate much easier.
Thanks, Doctor. And before we look at the film, can you help explain the anatomy of the cervical spine of the jury? If you have, like I did with the bones, the model,
Sure.
or we've got the pad and the helmet. If you wanted to sit down and draw it aloud. Doctor.
Sure, Doc, you can set that if you like.
Looks like the cervical spine of a dinosaur.
Yes. And we can use the helmet, and I've got pens here, or the model, or both, whatever suits your fancy,
All right.
to help the jury.
All right, since you have this nice big thing, we can start with this first. So, if you were looking into my neck from the side, the left side, and you've got X-ray eyes, you'd be looking into the neck like this. Now, obviously, this is about 3-4 times bigger than your cervical spine, which is about this big inside of you. But what we can see is a couple structures. You can see the front of the cervical spine, and you can see the disc, which is this kind of beige colored material in between each vertebral body. And so there are 7 cervical vertebral bodies. The first, usually on the x-ray from the side, they look square. So when you shoot all the way through it, it will have a square appearance. And then behind that and underneath that is the disc. When you look inside, this is the spinal canal, so the base of the brain would be coming down, and then the spinal cord would enter into this hole at the base of the skull, which is called the foramen magnum, and then it continues down in the spinal canal, such that if you look at the spinal vertebral bodies from the back, the canal is protected by this bone on the back, which is sort of like the roof of a house, and then these pointed things that we're seeing in the back of the spine, these are called the posterior spinous processes. So these are actually the things that you feel if you rub your fingers up and down someone's spine in midline. And in fact, this one here, which is the biggest one, it can be felt easily if you reach your finger right below the level of the collar, that big bump that we all have there, you're feeling this one. So one of the things that you learn if you're examining a patient is to feel for that big bump, C7. It's known to be C7, and then you can literally walk your fingers up the back of the person's spine and estimate, okay, that person's pain is coming from approximately the C4 level, for instance. So, let me do that. So there's 2 basic views that we'll look at on the MRI, and I'll draw that for you. So again, looking from the side, the cervical spine has these squared off appearing vertebral bodies the way they look on an MRI. We'll see that in a second. And in between each vertebral body is the disc. And we can draw that a different color if we want. So the discs are in between each vertebral body, and they serve as cushions between the bones, and they also allow the spine to flex and extend. So in other words, if the spine were one solid piece of bone, you wouldn't be able to flex or extend. Your spine would be like a broomstick. So we can label these vertebral bodies. The one with the pointed top, it has got a very characteristic appearance, and that is labeled C2 or cervical 2. And then we can go down from there, C3, C4, C5, C6, and C7. There are 7 cervical vertebral bodies. This one is labeled C2 because there's another unusual vertebral body here, which is C1, and it's basically a ring of bone, and that ring of bone articulates with the base of the skull. So if we have a person's eyes, nose, and mouth over here, the base of the skull where the foramen magnum is attaches by ligaments at this point. Now on the inside, we'd have the brain, of course, and the brain will feed down to the brain stem, and the brain stem will then pass down below the level of the foramen magnum here and pass into the spinal canal. So once it passes below the level of the foramen magnum, the name changes from brain stem here to spinal cord here. So it's just a continuous trunk of nerves, which is what the spinal cord is, and it is situated inside the spinal canal. Now the spinal canal is defined by the back of the vertebral bodies here and the back of the roof of the spinal canal here. So everything from here to here is the spinal canal. The white in the front or in the back and in the front, because remember this is the front of the patient here, this is spinal fluid. So the spinal fluid wraps around the spinal cord and bathes the spinal cord. The spinal fluid is actually produced in the brain and drips down along the sides of the brain. and then runs into the spinal canal and circulates down the spinal canal. At each level, there's a little hole right at the level of the disc space, and we'll see that on the MRI too, where the nerve roots can exit from the cord through the spinal canal and out the side. So at each level, we've got a nerve root coming out, and these nerve roots will run down the neck and then feed the muscles in the neck, feed the muscles in the shoulder, and then run all the way down to the hand. So we know that some of these nerves, like the C5, C6, and C7 nerves, run all the way down to the fingertips. In the back, as I said before, you've got these pointed posterior spinous processes, which we saw on the model, and the one at C7 is the biggest. And so this is the skin of the back of the neck here, so when you feel this area here, you can know you're at C7, and then you can count up from there. So this is one of the views, and these are the basic anatomy. I think there's more that I could talk about, or maybe we'll have to talk about more as we go on. But the other view, this one here was called the sagittal view. And sagittal means fancy medical term for side view, basically. The other view that we're going to look at is an axial view, and that'll be shown on the MRI as well. And to understand this view, basically what we're trying to do is we're taking a cut or a slice right across the disc space. So imagine this, and we'll see if we can understand it a little bit better. Imagine the patient is laying on a bed or gurney in front of you. I'll be the patient. I'm dead for this example, not alive. And so I'm laying on my back. Someone takes a bandsaw and cuts right across the neck at, say, a disc level. You're standing at the foot of the bed. Somebody else takes the body, moves it to the side, and you're left looking up into the neck at that disc level that was just cut through by the axial slice. That is the cut or cuts that we're going to take through the spine. So what we do is we take a series of these axial cuts, usually 3 cuts through each disc level, all the way down to the bottom of the cervical spine. So a typical normal disc will look like this. Move this over a little bit. So you'll have the disc itself there, and the disc is actually a 2-part structure. There's a thick outer wall called the annulus fibrosus, and then a jelly component inside here, and this is called the nucleus pulposus. So what herniates in the disc is when this jelly material herniates through the wall of the disc. So we like that jelly material to stay in the disc. Then behind the disc is the spinal canal. Inside the spinal canal is the cord. Behind the spinal canal is one of these posterior spinous processes. So remember, we're looking up into the neck, so the top of the person's neck, the front is here, that's anterior. The back of the person's neck that they're laying on the table, this is posterior. And because you're looking up into the neck, this is my right side, so your left eye is looking at my right side, your right eye is looking at my left side. So here, looking up into the person, this is right side, this is left side. So normal is when the disc comes around and it's just touching the front surface of the spinal canal, but it's not poking into the white spinal fluid, and it's not poking in, touching the cord. And remember I told you there's these neuroforamina, which are like holes on the side, and so at each disc level, the cord gives off a nerve root that will come out of this hole, and the hole is called the neuroforamen, neuro meaning nerve, foramen meaning hole or canal, and then the nerve would feed down the muscles of the neck and go all the way down to the shoulders and arms. So the classification of these discs is normal, bulge, protrusion, and extrusion. And so just really very briefly, because I don't want to go into too much detail with this, is the bulge means that if you have a normal disc, a normal spinal canal, that the wall of the disc is bulging out. It's stretched out over time, like this. And you can see as the thing begins bulging out, depending on how big the bulge is, the bulge may poke in enough that it's getting close to the spinal cord. It may touch the spinal cord. It may even indent into the spinal cord. And similarly, as the nerve is coming out, the disc bulge may be touching or impinging or narrowing the hole where the nerve is coming out, and it can cause the nerve root to have problems because it can irritate the nerve root. It can cause the nerve root to swell and thicken and have pain. Basically, you have to keep in mind the concept that the spinal cord and the nerve roots do not want to be touched. They're in this bony canal to be protected. So whenever an osteophyte or a bone spur grows into the spinal canal, whenever a disc bulges or protrudes into the spinal canal, it is putting that nerve or that cord at risk to irritate it and cause symptoms. So the other one that we see here is a protrusion, and a protrusion is a focal outpouching of the wall of the disc. So something like this would be a protrusion. So if we had this kind of finding, and say we got the nerve root exiting here and here, so if I told you there is a right, so we got right and left, there is a right paracentral means off to the center to the right, so center's here, right paracentral disc protrusion because it's focal, impinging upon the exiting nerve root on the right. This is what I would be describing. I'd be saying that the wall of the disc is poking out and it's getting close or touching the nerve root. And so in a patient like this, they may typically have symptoms on the right side but have no symptoms on the left side because nothing's happening to that left side nerve root. So the final one is a disc extrusion. And in a disc extrusion, basically the wall of the disc has split open, and in other words, say we start out with some kind of protrusion, the wall then splits open and allows the jelly material inside the disc to leak through the rent or tear in the wall, and it is accumulating as a glob of jelly material on the outside. And again, if you've got a nerve root that's exiting through that area, then this jelly material is pressing and encroaching upon the nerve root, which can then cause symptoms for the patient. So these two right here, protrusion and extrusion, these are called HNPs, or herniated nucleus pulposus. These are the two forms of herniations, protrusions and extrusions, and then the other classification over here is bulge. So basically things can be divided into normal, bulge, and two types of herniations, protrusions and extrusions.
Thanks, Dr. Foley. Do you think at this time you could show us the actual MRI film, or was there more that you wanted to?
No, I think this is good. I'm just going to have to transfer my computer over here.
Yes, please.
And plug into some power, maybe.
Yep, we've got power right here for you.
Okay.
So could you help us understand what are we looking at here?
Okay, so let me get my report too, because I want to tell the jury accurately what I told you.
Thank you.
So this is an MRI of the cervical spine, and it was done on 6/16/2013. So everything that we're looking at here is of the patient, Dannette Griffith. This is not anybody else's pictures. And so we have two sets of pictures. We've got that side picture, which is called the sagittal view right here. And we then have also an axial picture, which is over here. Let me find an axial view for you. This one. Let's see. Okay, so we'll start out here. These are the axial views, which we'll see in a second. And let me see if I've got this one right. Okay, so I don't have a laser pointer, so I'm just going to try to use this white arrow on the computer to point some things out to you. If you look at this sagittal view, we can see that one of the first things you want to do is identify your orientation. So your orientation is to find C2. And so this is the back of the skull right here. The tongue would be up here. This is the front of the neck, and the chin would be out here, and the eyes would be up here. Inside, you can see the pons and midbrain right here. This is where your respiratory center is. Once you get below the hole at the base of the skull, this is the foramen magnum. And so now we go from brainstem to cervical spinal cord right here because we're below the level of the foramen magnum. Then identifying your disc levels, we look for the pointed top. So this is C2, and now we can count C2, C3, C4, C5, C6, and C7. And then this is T1 down here. Now we go into the thoracic levels. One of the things that we can notice right away is this person has had surgery because we can see this black thing right here in a black and white area and black and white area here. These are actually metallic screws that are screwing into the vertebral bodies, and this big black thing that we're seeing here is a metal plate that has been applied onto the front of the cervical spine, and it's held in place and screwed in by these screws. So what that does basically when we talk about the adjacent disc syndrome is it causes these discs, this disc here and this disc above it, to get a better, more of a workout than they otherwise would have had because these levels right here at C5, 6 and C6, 7 are fused. So the other thing that we can notice is that this person has some underlying degeneration present. The discs are dark. Normally the disc should have a white jelly center to it, and it's black. So white would mean accumulation of fluid, and the discs normally have fluid in them. When they are degenerated, the disc loses fluid and then can turn totally dark and black like this. So we have a desiccated disc at C2-3, another one at C3-4, another one at C4-5. Then at 5, 6, and 6, 7, these are fused discs. And then at 7-1, we have a desiccated disc again.
Doctor, is the desiccation sort of a natural thing, or is it traumatic or a combination?
It is. The vast majority of disc desiccation is just degenerative in nature. So, I mean, it's sort of like, is it natural for a person as they get older that they might get gray hair because your hair follicles stop producing color? That's normal. Some people are able to keep their hair the same color when they were a teenager all the way into their 70s or 80s, but for most of us that's not true. Your hair tends to lose color as you get older. So it is a normal age-related degeneration of the disc.
Do her discs look like the average disc of a 47-year-old female?
They do. I mean, unfortunately, as we get into our 40s, we begin to start showing degenerative changes like disc desiccation. Right here, for instance, notice this is at the C2, 3, 4, 5 level. Notice that we have quite a prominent osteophyte sticking out back here, along with a disc sticking out as well. So this would be called a disc osteophyte complex right at this level. Now you can see with that kind of finding, one might wonder teleologically, why did that develop so prominently like that when these other levels look somewhat flat? And one of the thoughts would be that because you fuse this level, you're now causing this level and the level above it to have a tougher workout, if you will, and they will degenerate more rapidly and they will herniate more easily when exposed to trauma. So the thing to notice, though, is the body's protective mechanism is to develop bone spurring because it's thickening the bone up there with the idea that you're going to try to make it stronger. But in reality, when it gets big enough, the very thing that your body was trying to do, which is to protect you, is now poking so much into the spinal canal that it's actually very close to the spinal cord, much closer than any other disc level that we're seeing in this picture. And that can be a site where if you're in a trauma and the cord gets pushed forward against this, you can cause localized trauma to the cord itself and then cause neuronal damage to the point where the person gets continuous symptoms, even though when we look at this and we could argue, well, I don't see it touching the cord, though. There's still a little white spinal fluid there. What is that guy talking about? But at the time of injury, the cord could bounce off that, get an impact on the cord, and then cause a problem.
Doctor, does the cord move when the person moves?
It does. That's a good question because obviously we're looking at static images here. But as you say, if this is the cord in my hand here, this is the back of the disc here. As you flex forward, the cord will slide in the spinal canal a little bit, and it will lean up against the wall of the spinal canal and the disc. So if you've got something sticking out and it's laying next to the cord and you're bending forward, it's going to wrap around that area, and then so that constant flexion extension keeps touching and untouching the cord, which is going to then cause symptoms and irritation to the cord. But the other thing to do now is to notice what these discs look like. See, so I'm kind of toggling. If you look at this, I'll show you how this works. See the yellow line over here, at least it looks yellow to me, is marking where we're sampling over here. So if I go way out, if I go way over here, I'm out in the neuroforamen, and that's why we're seeing these holes where the nerves are exiting out to the side. If I bring the cursor more towards the midline, like this, then this is letting me know that I'm at the midline cut on the sagittal view. But this happens to be a particular level that I want to show you. I want to start out with going up to C3-4. So at C3-4, this is C2-3, so that's C2-3 disc, this is C3-4 disc. We have a disc that on the sagittal view looks like it's sticking out, looks like it's touching the cord, and so if we go ahead and study that or interrogate that level by getting the line to go through it, we can see that the disc is actually focally sticking out at that level and is actually touching the cord. So what we want is we want to see nice white spinal fluid being in back of the disc and in front of the cord with a nice cushion of white spinal fluid present. We do not have that here because we have the disc focally sticking out, and if you remember the picture that I drew for you, if it's focal, that would classify as a disc protrusion, which is a form of herniation. And so clearly we can see it's not broad-based going all the way across. It's focally sticking out and it is touching the cord. The other thing to look at is because we know fluid is white, so like spinal fluid is white. Here's the jugular vein. Blood would look white in the jugular vein. Carotid artery right here. So whenever you have fluid accumulation, things look whiter or brighter. This disc, instead of being dark colored like it should be, especially think about the disc on the sagittal view, how dark that is. On the axial view, we can see not only is the disc sticking out, but it is bright white as well, which would imply it's got fluid accumulation in the disc, which generally is often associated with edema or fluid swelling within the disc. And that is a finding that sometimes you can see in an irritated disc, for instance. So this person disc looks like it's what we say in the vernacular, it looks like a hot disc. It looks like, if I had to guess, one of the discs that is probably bothering this person, it would be this disc because it has got that white signal intensity in it. And so it's an interesting observation.
When you say hot disc, doctor, is it the disc that's going to be the pain generator, or is it the contact with the spinal cord?
Well, several things. So this enters into a discussion of MRI is a macroscopic study. It allows you to see the general appearance of the vertebral bodies, the discs, and so forth. To answer your question, certainly that disc sticking onto the spinal cord will cause symptoms in the vast majority of people. That the nerve doesn't like that, the cord doesn't like that. What we forget, though, is we can see macroscopically that disc is sticking out. What we're not seeing is that all surrounding the disc, there are little tiny fibers, nerve fibers called annular C fibers, that are smaller than a thin piece of hair, so that they're not resolved, they're not seen by the MRI. But if this disc was herniated out and blown out, say by a trauma, it is naturally going to not only rip the wall to open up and allow the disc to stick out, it's going to tear any kind of little thin fibril nerves that feed all the way around the disc. So this is why in some people you could have a totally normal looking disc where it's totally flat, and you look at it in MRI and say, well, I don't understand. The patient's having pain from C3-4. Everybody's done a physical exam and agrees that's where the pain is at. Yet we do the MRI, the MRI doesn't show us anything. I mean, the disc looks totally normal. Well, that's because during the process of trauma, the disc could have been bulged out so much it ripped the little tiny nerves around the disc. Then when it comes back to normal, the disc comes back in, and yet the damage is done to those little tiny nerve fibers that you can't see on MRI. So we all focus on what we can see, but what we have to remember is there's lots of things that we can't see on the MRI. I mean, it's sort of like if we went back to the 1800s and asked somebody to believe in radio waves or, our cell phone being able to talk to somebody 50 miles away, they'd say, like, you're crazy. I mean, I can't see it, so I don't believe it. But we know that these things do exist.
So, Doctor, are you saying that the limitation of an MRI really is just the computer, the pixel, the resolution of the picture?
Yes, I mean, you can only see down to a certain level, and it won't resolve below that. So the tiny fine structures like these little annular C fibers that wrap around the disc cannot be seen, but we know they're there because you can see them under a microscope, for instance.
C fibers are nerves.
Yes.
And how big are they in comparison to other structures that we can see?
Right, well, the common one that I hear about all the time is a red blood cell, which is super tiny, is 5 microns in size. So I mean, like, say, if you cut your finger and you bleed, you can tell you're bleeding because you see red stuff coming out of your finger. But if I ask you, are you seeing individual red blood cells there, or are you just seeing this red fluid leaking out of your skin? You say, well, I'm seeing red fluid, that's blood. Right, but I mean, are you seeing individual red blood cells? Can you tell me there's 10,000 red blood cells there, or 50,000 or whatever? You can't. So if we drop that blood on a microscopic slide and look at it, we could see that all the individual red blood cells, if you measure them, they're 5 microns in size. The nerves that feed around the disc are 1 micron in size. They are 1/5 the size of a red blood cell. So they're super tiny, yet they provide pain sensation to your disc, so that if you rip those, your MRI might even be normal, and yet the person has, severe pain because they've torn those little tiny nerves that you can't see on an MRI.
Thanks, Doctor. So if you could, I think your opinion is that one protruding disc is sort of the most important diagnosis finding you've got?
Well, now there's a couple of things. I just want to take the jury back one level, and then we'll track down real quickly one by one. So to give you an idea of a more normal looking disc, at C23, we can see that the disc is smooth across, it's not sticking out, there's a nice zone of white spinal fluid between the front of the cord and the back of the disc. And if you look at it on the sagittal view, it looks nice and flat, as opposed to the disc below that we just got through looking at, where when we come down, we can clearly see the disc is sticking out, and it's coming close to the cord there. When we look on the axial view, we can again verify that disc is sticking out, it's touching the front of the cord, and it's diffusely white, suggesting that it's irritated. Now, as we go down further, we're at C4-5, and at C4-5, we can see that there's a bony osteophyte here. Let's see if I can clear this out of the way. This little pointed margin here is the bone spur right there. And when we look at this, we see it's smooth across, but it's kind of sticking out into the spinal fluid. So this would classify as a disc bulge osteophyte. So this finding here is more of a chronic degenerative finding, whereas this finding here is more suspicious that it's a pain generator because it's got the white signal in it and it's touching the cord. Now, as we go down into the next level...
Before you go too far, let me go back to that osteophyte.
Yes.
Can you tell the jury, approximately how long it takes for the body to build or have an osteophyte?
Sure. So normally it takes somewhere around a year. A year is the ballpark figure most commonly quoted. If you ask, well, what is the absolute minimum time that it would take to get an osteophyte, that is quoted to be around 6 to 8 months. So generally when you see osteophytes, they're usually of some age. They've been there at least 6, 8 months, probably a year or even many years.
And just to create the timeline, this MRI was done 6 years after the trauma.
Correct. That's right. So the person, we don't know. We don't have another MRI to look at, but to look at this and say, well, that's an osteophyte, so it couldn't have been caused by the accident. Actually, it could have been caused by the accident. It had 6 years to grow to look like what it is today.
That's my point. Do you think more likely than not that was created as a result of the motor vehicle crash?
Well, I don't want to lean too far one way or the other. I would say it's a definite possibility, and you've got to correlate it with the patient's symptoms.
Okay.
So if clinically the person is getting pain from C3-4 and C4-5, I would say those are the two likely areas that it could be injured. So going down further, now we're getting into the fused area. So let's go look further. We finished 4-5. Let's look at 5-6. Now C5-6, it looks like it's kind of messed up on this view because this is where they suck the disc material out and put bone graft in and then put the plate in the front. But here's what the problem is. This is an operated area, but look at the back of the vertebral body. It's got this big, irregular looking osteophyte that's touching the front of the cord, and the cord is actually very narrow in this spinal canal. It doesn't have much reserve of this cord to be able to get pushed back further. So, when a surgeon comes in and operates on the disc, they come in from the front side and they suck the disc material out, and then they put the plate in the front and the screws in the front. Typically, they can't get all the disc material out because you're getting towards the back edge of the disc. And if they push too far, they might poke through the back wall of the disc and get into the spinal canal, which would be a veritable disaster. So the other thing that they can't do is when you're coming in through the front, you can't shave this osteophyte off because you're inside the spinal canal at that point. So when this is done, when the fusion is done, it's done with the hope that by fusing this, it will stop this osteophyte from rubbing on the cord. But you can see here, it's even deflecting the cord backwards into the spinal canal, and it's a very ratty, irregular looking osteophyte. The point is, this person went into the accident with pre-existing fusion at that level. So if you have anything like that or similar to that, you can imagine when you undergo a quick trauma, you could whack the cord right up against this irregular osteophyte and cause neuronal damage to the front of the cord. And again, you have to correlate clinically. I'm not here to say definitely yes or definitely no. I'm just presenting to you what the significance of that finding is.
When you say neuronal damage, are you talking permanent?
Yes, most neuronal damage doesn't go away. In rare instances, you may get some partial healing, but neuronal damage is a bad thing, and usually the person is left with some residual pain, residual symptoms, something. So when we go down to the next level, this is the other fuse level right here. Now we can tell we're at the lowest fuse level. Here's that last screw going in at the C7 level from the front. And this is the C6-7 disc space right here. Again, look what's going on in the back of the disc there. It's poking out and it's indenting. See, this cord should be nice and round and oval. So if you follow the roundness around, it goes here, then it dips back at like a concavity, like a little cereal bowl there, and then it continues around again. So this is actual impingement and impression on the cervical spinal cord at this level, and this is a fused level. So that person likely has had that there for a long time, and then when exposed to trauma, that can irritate and activate the cord and injure the cord, even though the level is fused. So again, this kind of relates back to the so-called eight-shell patient, where they have certain underlying degenerative problems that if you leave them alone and they're very gentle, they're okay. But as soon as you put them into a trauma, even a relatively small trauma, it can do enough to injure the cord because it doesn't take much. It's already pressing on the cord. And then we go down to this last level, which is C7T1, and this level is fine. There's nothing pressing on the cord or the nerve root. So those are the main findings.
Okay, thanks, doctors. I think that we need to show the jury on the phones then.
I think they got
All right, if you don't mind, thanks a lot. But when you talk about clinical correlation, can you explain that to the jury just to make sure everyone's on the same page?
Yes. So clinical correlation basically means that you take all of the data that you have and put it together to make a final diagnosis. So the data that a clinician might have is they know the results of the MRI findings. They would have laboratory tests, which generally in the spine cases, it doesn't matter one way or the other, whether you have low hemoglobin or hematocrit or elevated white blood cell count. They have the history, they have the physical exam findings. So when they get all of that together, the history, the physical exam findings, when the patient's symptoms change from whatever they were before to a new or different set of symptoms, and correlated with something like the MRI that shows you things are going on at multiple different disc levels, and we have various types of herniations that are sticking out into the spinal canal and pressing on the cord and the nerve roots, then they can come to a determination of whether the person more likely than not underwent an injury in the particular case.
Let's talk about one thing you said, changing symptoms. How important is that in making a causation opinion?
Well, it is important because, see, as you get older, it's relatively rare that you're going to run into a patient that can honestly raise their right hand and say, I never had a symptom in my life. I'm 60 years old and my neck has never bothered me one day in my life. And as a human being, almost everybody has woken up one day or another and had a stiff neck or a sore back just from stuff you've done over the weekend or whatever. But so a person, say a person has arthritic change and they have some kind of low-level neck and back pain every day. 1 or 2 out of 10, generally something low, not enough that you're needing surgery, but you may go see the doctor every once in a while and say, my neck's flaring up again or something like that. Fine, got back pain 1 or 2 out of 10. Then you get in an accident, and now your neck pain isn't 1 or 2 out of 10 anymore, it's 5 or 6 out of 10. And you're waiting for it to go away because like most of us, we don't like going to doctors. We'd rather sit at home and watch TV or be in our own homes. But after 2 weeks or 3 weeks or a month or a year or whatever, it's not going away, then that's a sign that you've got some kind of permanent injury, permanent aggravation. And at some point, people have to make the decision, am I just going to learn to live with this and put up with this, or am I going to see if someone can help me and do a nerve root block, or am I going to see if surgery would help? So there's all sorts of options out there after that. But generally, when you see a longevity of a continued higher level of pain than what you've had before, that would be a sign that you've injured that area, and it would be like a permanent injury.
Dr. Foley, I'm going to ask you sort of a question. I'm going to assume a couple things. One, that the person is a pedestrian, they're injured in a car crash in 1999. They have surgery of fusion at 2 levels in 2000. Then they seem to stabilize. They're working, everything's normal. They have a car accident in 2002. The pain level spikes up. They have, pain, but then it calms back down. 2004, they're involved in another collision. Pain's back up there, maybe an 8 out of 10 or 9 out of 10. But then it goes back down. 2005, a slip and fall. Pain goes right back up. Then after that, it subsides, and they're not going to any doctors. In fact, there's 2 years where there's no medical treatment or complaints of back pain. Then they get into a relatively minor, low-speed, no property damage crash, and suddenly the pain goes up, and never seems to really resolve itself. Would that be the type of clinical correlation that would point back to say that this motor vehicle crash in 2007 was the cause of these ongoing persistent problems?
Yes, and that would be the example of a classic eggshell patient too, where the person's had prior problems in the past because of underlying osteophyte changes and degenerative changes, and then they have another accident which, and analyzing it, would say, are you kidding me? I don't believe that person was injured. You know, I mean, that thing was 1 mile an hour or whatever, and yet to that spine that's already pinched by something that's poking into it, it causes damage to the spine, and guess what? It doesn't spike up and then come back down a week or two. It stays there, or stays relatively high as opposed to dropping back down to 1 or 2 out of 10.
Doctor, in the MRI, you showed us this area, I think you used the term irritation.
Like,
Is that like because something's going on every day and causing continual irritation? Is that what we're looking at?
it is, and you know, I think I left my pen in my car, but I can use my glasses. If my back of my hand is the spinal cord, say, and let's say this tip of my eyeglasses is the disc or an osteophyte. If I hover the tip of my glasses right above my hand, I'm not feeling any symptoms. Matter of fact, if I close my eyes, I really don't even know how close that is to my hand, even though it may be very close to the cord. Okay? Now, if that disc gets just a little bit bigger because of the trauma, or if the osteophyte is now poking into the cord, you may have some kind of symptoms. But here's where the real problem comes in. We saw that one or two of those osteophytes are poking into the cord. The problem is that is a static picture. That's not showing how that cord, every time you move, is dragging back and forth across the cord. So when you're flexing, extending, flexing, and extending. So the example would be, I had an attorney do it to me one time, and it was amusing because I think he cut me a little bit, but he took a paper clip and he opened it up, and he says, I want you to think that this paper clip is the disc or the osteophyte, and it's touching your hand. Do you feel it touching your hand? Yes. Okay, now I want you to assume that during the motions of daily living, the person flexes and extends their head up and down multiple times. So I'm going to take your hand and I'm going to rub it back and forth for like 30 seconds. So he's just like scratching the top surface of my hand. He said, so that would be like an irritation, right? Just from movement. Now what if I did that every day in the same spot for 30 seconds every day? Scratch, 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 scratch for 30 seconds. You get the rest for the other 24 hours. And then do it again the next day and the next day and the next day for years. I mean, that area is going to be raw. It'll probably be bleeding every day. So the problem with a lot of these things, like these discs that are sticking out and the osteophytes that are sticking out, is it's not like they go away at night or suck back in and go to sleep or something like that. They're sticking there, and which is the reason why, for instance, when people do go to bed, sometimes people will feel a little bit better after laying down in bed because they're taking the pressure off. But when they get up in the morning, within an hour or two, the pain is back again because they've now started moving around again, and those things are rubbing again on the nerves or the cord.
Thank you, doctor. So are you saying that in Dannette Griffith's situation, that irritation is something that's ongoing and not resolved?
But that based on these kind of findings, that would be very typical. I would say yes.
Is that a permanent injury?
Well, it is a permanent injury, and a sign of a permanent injury is that it doesn't go away. So, I mean, generally, things that are aggravations but go away will resolve themselves in a matter of a couple of months, like a month, 2 months, 3 months. But if you get a new symptom and then it's continuing on and on for months and years, then that is a sign of a permanent injury.
Okay. Now, after the motor vehicle crash, there's a couple instances where Miss Griffith has fallen down and had exacerbations. but then her symptoms seem to go back to about the baseline. Are those permanent exacerbations or are they temporary exacerbations that they go back?
Right. So like if she
Objection, Your Honor. Outside of his area of expertise.
Oh, go ahead.
So she, prior to the accident, had been hovering around a 1 or 2. I'm kind of hypothesizing.
Right.
I have not looked at medical records,
Yeah.
but just to answer the hypothetical. And then the accident, she pops up to a 6, say 6 out of 10, and then has a little slip and fall at the house or whatever. It pops up to an 8, and then it drops back down to a 6 again. Then that would be a temporary aggravation, that jumping from 6 to 8 because it came back down. But the difference between jumping up from the 1 to 6 and pretty much staying there the whole time would be the permanent injury.
And so it's a permanent aggravation of a pre-existing condition.
Right.
Is that your opinion is what she has?
Right. Well, you totally can't exclude. I definitely think that the patient, based on the findings, would most likely have a permanent aggravation. But one of those discs may have actually blown out during the course of trauma too, because you had so much degeneration at all of those levels. So that focal thing that I showed the jury that was sticking out, that if you've got a thinned out degenerated disc and you have a trauma and you're putting a lot of pressure on it because the levels below are fused, that thing can pop and put pressure on the cord right there, and you've got a problem.
Right. Let me ask you, her fusion's at the lowest cervical bone, right? So the next bone below that is T1, which is thoracic.
Right.
Is that the vertebrae that have the ribs coming out of it?
It is.
What is the significance of the mobility of the disc at the thoracic level?
Right. Well, in general, the thoracic vertebral bodies are much more stable than the cervical or lumbar because you do have the ribs attaching to them and all the intercostal muscles between the ribs, so it kind of holds the thoracic spine relatively tight. When it comes to the disc, in the thoracic spine, you can get bulges and so forth like that, but it's not typical to get an acute herniated disc in the thoracic spine. With regard to the level you're talking about, the next level down, T1, 2, it's not surprising you might see a bulge at that level or something like that, but if with this person's fusion, the way it is, 5, 6, and 6, 7, if you have a choice, and we're going to ask you to vote, which levels do you think would be more likely to get injured from trauma? Would it be the first thoracic level where you have the ribs wrapping around and it's just below the lowest screw at C7? Or would it be the 2 disc levels above where there's no ribs attaching to that area? And the answer would be the disc levels above. And in fact, when we look at the MRI, we've got the disc protrusion at the C3-4 level that's white hot, and we've got the disc bulge osteophyte complex, which is poking significantly into the spinal canal, and both of those are immediately above the fusion site.
Doctor, have all the opinions that you told the jury today based within a reasonable degree of medical certainty?
Yes, sir.
Thank you very much. That's all the question I have.
Thank you.
Thank you, Your Honor. Please, court. Mr. Powell. Good afternoon.
Good afternoon.
Doctor, you only looked at one MRI, correct?
Yes, sir.
All right. Now, you as a radiologist are not able to render an opinion about what caused the findings on that one MRI, correct?
In this case, no. Normally, or I wouldn't say normally, but in about half the cases that I do review, sometimes the attorney will send me the medical records and the films, and then I can give a causation opinion. In some cases, if they already have somebody, a treating doctor or something that's going to give a causation opinion, then they don't need me to demonstrate the findings on film. So that's why that's all I did in this case.
Right. So you've gone over the findings from a period of time, quite a long time after the date of the accident that we're here for, which would show why Ms. Griffith feels the way she does today.
Sure.
Okay. But you don't have an opinion within a reasonable degree of medical certainty and or probability that the June 6, 2007 motor vehicle accident were the cause of the findings on that particular film, correct?
I agree with you, and I agree with you because in order to have that opinion, I would have needed to review the medical records to be able to say the patient's pain was at this level, but after the accident, it jumped up to this level. So in the absence of having those kind of records that I would have reviewed, and to be fair to the whole opinion, I'm not going to say that opinion because I'm not combining the two together.
Right. And it would be ordinary in your business as an expert radiologist to look at more than one set of MRI films, and then you can give an opinion about interval changes, if there are changes that occur from one point in time to another, and then find out, well, what happened in that period of time with the person.
Right, if the person had a bunch of MRIs. You know, a lot of times people don't have 5 or 6 MRIs, but obviously if there were more MRIs, I'd be willing to look at those.
All right. Thank you, Doctor.
Thank you.
All right, and you're right.
A little bit. Doctor, based upon your testimony, I want to make sure that I'm clear. Your opinion is still that there's objective, clear evidence of trauma, and that's within a reasonable degree of medical certainty. You're just not dating the exact date that happened.
Right, because I would need the medical records to do that.
She's got a hot disc or a hot neck.
Right,
It's just irritated, inflamed internal.
exactly.
Okay, thank you, Doctor.
Yes.
Any other questions for the doctor? All right, doctor, you may be excused. Thank you.
Thank you, Judge.